talk of too much of pathology. I know I'm talking to surgeons. First of all, thyroid FNAC, Dr. Suman has nicely explained you how we do FNAC thyroid in Raton Memorial Center. Most of our FNACs are done under ultrasound guidance, so make sure that we get minimum number of non-diagnostic or inadequate FNACs. So it's a procedure of choice for evaluation of thyroid nodule. It is rapid, cost-effective, reliable tool. It helps us to triage the patient, whether patient should go for surgery, whether patient should go to endocrinologist, or can be just active surveillance done in these patients. And accuracy of diagnosis, as earlier explained, it entirely depends on the skill of the radiologist or pathologist or surgeon who is performing FNAC, and skill of the experience and training of the pathologist who is interpreting it. Now, indications again, not I'm going to go into detail. Dr. Suman has explained it very nicely. Any suspicious nodule that is on imaging, besides that, clinically suspicious nodule, that is some family history of cancer, prior history of radiation, and any node, all FDG lesions, they can be aspirated. What we expect from surgeons and radiologists for FNAC is give us all this information, what is listed here. This is very, very essential. Let me tell you, because we in Tata, we are privileged, as I always say that, because we have EMR, electronic medical record, we go to EMR, get all information, look at the radiology findings, look at the thyroid score. Because of this, if there is any discrepancy, we make sure that we put it in our report, that if it is saying thyroid 5 and we are calling it Bethesda 2, which is benign, definitely this is not a representative FNAC. So that's why a pathologist needs all this information. It's not that we are going to make our decision or prepare our report based on all this information. We need this to make sure whether we are in line with that, whether it is discrepancy, and in that case we can inform the radiologist and the surgeon that there is some kind of discrepancy, please reevaluate. And FNAC procedure, I will not go into the detail, again it is explained very nicely. I want to quickly talk about this rapid onset evaluation rules, which all institutes should develop that. We keep talking to pathologists also. This has definitely improved our yield and less number of non-specific or non-diagnostic FNACs, because there, as Dr. Suman explained, the radiologist is performing the FNAC, the cytotechnicians is there who is immediately preparing the smear, rapid staining, and cytotechnologist or a pathology resident is there to look at whether it is adequate or not. This is actually just if one or two passes are not giving you adequate FNA material, the radiologist can go for third pass. If first two passes are giving adequate material, no need to poke the patient again. And thus it reduces number of FNAC passes, number of FNAC attempts, and number of ultimately cost to the patient. As I said, it involves radiologists, cytotechnologists, and pathology resident. This is our setup. We both at Tata Memorial Hospital, DMH and ACTREC. We have rapid on-site evaluation facility available. Now, we have done the FNAC, and when we get the FNAC in pathology laboratory, there are multiple challenges. We get this inadequate sample. Sometimes it is too hemorrhagic, too much of blood masking all the cellular details. Now, believe me, there are so many overlapping features in many thyroid tumors as well as benign thyroid conditions and neoplastic thyroid conditions. And the classification system now, it has evolved a lot, and to the point we may not be able to classify those tumors on FNAC alone. Smaller nodules again sometimes can pose a problem. So what should we do? Previously, I'm sure all of you must be getting this kind of reports. We cannot exclude malignancy and all those descriptive material. The cells are big, the nuclear big, there are grooves, and there is this and there is that. I'm sure from surgeon perspective, you must be saying, don't tell me all these things. To come to the point, tell me what it is and what should I do next. And that's what it was necessary in pathology nowadays. It's not just description. At the end or at the top, you have to give an impression which is really relevant for the end user, that is clinician or oncologist. So what happened is 2007 to establish a comprehensive interdisciplinary information dialogue between all these specialties. They developed this Bethesda system, which included pathologists, radiologists, endocrinologists, and surgeon. All of them, they came together, they discussed for a period, and they developed this Bethesda system for reporting thyroid cytopathology. Now remember, this is optional, but it is strongly recommended. And definitely, since we have been using it more than 10 years now, 10, 15 years almost, and it has improved our understanding a lot. And this is the book, now it is third edition. It gives for pathologists, is an excellent book out as a referral book. So what is TBSRTC, or the Bethesda system of reporting thyroid cytopathology? This is a summary document which includes indications, what is the training is required, credentialing technique, terminologies and morphology criteria, that's for pathologists, ancillary studies including immunohistochemistry and molecular techniques, that is again for pathologists, and post-FNAC options for testing and treatment, this is for clinicians or oncologists. So what are those categories? The categories, as you see here, the categories are 6, 1, 2, 3, 4, 5, 6. One is non-diagnostic, second is benign, third is ATP of undetermined significance, which means we really can't say whether it is neoplastic or non-neoplastic. Then follicular neoplasm is 4. Here I want to put an emphasis. We can't go beyond follicular neoplasm. We cannot differentiate between follicular adenoma versus follicular thyroid carcinoma, because that requires tissue where we need to look for capsular and or vascular invasion. Then number 5 is suspicious for malignancy. Number 6 is malignant, and in malignant, if possible, we try to give you what type of malignancy. It is papillary thyroid carcinoma, is it anaplastic? Especially important to act on this patient immediately, or sometimes suspect medullary thyroid carcinoma, so get serum calcitonin levels and so on. Now how does it help us? And this table clearly gives us what is the risk of malignancy. If you see the central portion of the center column, each category has its own risk of malignancy. And this way we really know how this Bethesda terminology is useful for us and what to do, usual management. You can see that non-diagnostic needs repeat FNA, benign needs follow-up, but from AUS onward, till suspicious of malignancy, molecular testing can be used if available. That's another thing, that it may not be available at each and every place. And then when to do lobectomy or near total thyroidectomy, diagnostic lobectomy, all these tips are given in depending on Bethesda type of the lesion. So ancillary studies, can we do that? Immunohistochemistry, very rarely we are doing it, especially when we are suspecting medullary thyroid carcinoma. Again, we don't do it. We ask clinicians to get serum calcitonin levels, which is the easiest one, which is required in these cases. Now, molecular studies, it can be done. Now, in our part of world, molecular studies are not commonly used, I know, but sooner or later they will be done. We may not be able, our patient may not be able to use or afford this Afirma and Thyroseq version 3 and further versions, but definitely in-house molecular tests, and in Tata we do have a small 7-gene panel which is kind of affordable to many patients, and that can be done if required on FNACs. So let's go to molecular pathology. Here I want to explain the recent thyroid classification. If you can take a look at those entities in the red square, you can see that there are benign tumors, low risk neoplasms, malignant neoplasms. Now among the malignant neoplasms, these are follicular cell derived and C cell derived. What is the difference? The follicular cell derived thyroid carcinomas are maximum. They are almost more than 95%. What do they include? They include all of this: papillary thyroid carcinoma, all the variants, follicular thyroid carcinomas, medullary thyroid carcinoma, poorly differentiated thyroid carcinoma, and anaplastic carcinoma. While C cell derived thyroid carcinomas, these are fewer, but these are medullary thyroid carcinoma. So if you look at the follicular cell derived tumors, you can see that there are three classes now based on the outcome. And now how do we divide in pathology? We take a look at the nuclear features, mitosis, necrosis, and the histologic architecture of the tumor. Now based on that, if you see first entities, papillary thyroid carcinoma and most of its variants, follicular thyroid carcinoma and opposite carcinoma, which was previously called as Handle cell carcinoma, they all of them have a favorable outcome. Now, there are two entities, poorly differentiated thyroid carcinoma and another one is differentiated high-grade thyroid carcinoma, recently introduced in newer classification based on presence of necrosis and more mitosis. Now, these two entities have intermediate outcome. It is worse than differentiated ones, but better than anaplastic. And lastly is the anaplastic, which all of us know, it is poor outcome. Now coming to the molecular alterations, we had excellent lectures earlier, and just I want to repeat the fact that there are driver mutations and then there are further mutations which can lead to poor differentiation. If you are the driver mutations, usually they involve MAPK pathway. Most of them are mutually exclusive. BRAF you have heard so far many times, which is the commonest mutation. RAS is another mutation. Then you see red PTC and other mutations in thyroid. I'm not going to go into the details of each and every mutation, but how these can be translated in our clinical practice. So BRAF-like tumors, just we can remember there are BRAF-like tumors and RAS-like tumors. This I'm talking about differentiated thyroid cancer. BRAF-like tumors, they are less differentiated. They include classical type and its variants include tall cell type. While RAS-like, these are follicular pattern tumor, follicular thyroid carcinoma, follicular variant of thyroid carcinoma. These are all RAS-like tumors. And these are the different features of both the types of tumors. Red PTC can be seen in the first group again. RAS mutations are infrequent in this. Now the thing is that the BRAF type tumors, they frequently go to nodes and many times also distant metastasis, while the RAS type, they usually are associated with distant metastasis. Nodal metastasis is very, very rare. Medullary thyroid carcinoma, we know there are sporadic and germline mutations and red point mutations are there, red gain of function mutations are there. They are associated with MEN2A, MEN2B and familial medullary thyroid carcinoma syndromes. Now, how molecular pathology can help us? First and most important, we heard about in the morning lecture and also later on, molecular pathology is very essential nowadays, especially in selected patient for targeted treatment. And here the tissue or FNAC can be submitted to NGS and targeted treatment. This is a small list definitely, but these are the agents that can be used. There are more and more agents being added. Now, do we need molecular testing for all? As Dr. Shah explained nicely, BRAF immunohistochemistry can be done in selected cases whenever required, and that is very good. But for rest of the targets, we need molecular testing, including NGS. Now, there are different platforms, Thyrosec, Afirma, Thygenex, and then Rosetta. All these are in the outside countries, Western countries. They are not really affordable to majority of our patients, but those who can afford, they can always avail this opportunity. Given there is this positive predictive value and negative predictive values already included in this one. So what are this rule in and rule out tests? So before I end my talk, let me talk about the rule out test and rule in test. Rule out test is low molecular probability of cancer. That means you are thinking it's you don't want to avoid the surgery, and there the rule out test can be helpful. If it is positive,